And last but not least in our presentations this morning, we've got Dr. Venkat Subramanian, who's going to talk to us about new approaches, or current and new approaches. Yes. I think if you just go to the next slide, it would be Amy.
Good afternoon. Thank you for inviting me to speak today. So from those two wonderful basic science lectures, we're going to move away a little bit to more data-driven analysis and sort of clinical approaches to how we treat pain. And as I was given the dreaded pre-lunch slot, I realized that I'm going to lose a lot of you if it runs a little bit over. And so actually, sorry, my title gives you everything you need to know about pharmacological approaches to pain. So if you want to switch off now, no problem. The problem is one of, I was going to talk of choices and consequences, but realistically, it's the lack of choices and the number of consequences of these kind of pharmacological treatments that actually underpin our treatment of pain in IBD. So I try and be very brief. So we'll talk a little bit about the epidemiology of pain in IBD, go on to what the current pharmacological options are, and intermingle that with the complications of using these kind of pharmacological treatments to pain in patients with IBD. Very briefly touch on what novel medications we can expect in the future, and give you my conclusions on this topic. So I think something that we've all been telling throughout today has been that abdominal pain is quite common in patients with inflammatory bowel disease. But it is an underreported and under-recognized symptom, especially for physicians like myself, as we tend to brush that under the carpet, because we are happy treating patients who have inflammation, but we're not that happy treating patients who've got pain but no inflammation. The pathogenesis is still unclear, and a lot of patients have persistence of pain despite good disease control, and that's where we tend to fall down. And there is very poor correlation between pain intensity and disease activity in many of these patients. That makes it very difficult to deal with. So what is the epidemiology of pain? How common is this? And the data varies. So Crohn's and Colitis UK, NAC as it was known in 2004, did a survey of their members and found that 50% of patients with Crohn's disease and about 37% of patients with colitis had pain irrespective of disease activity. There was a survey done in Europe, the European Federation of Crohn's and Colitis Associations. This was in 2012, and 62% of patients in this cohort reported daily pain, and with almost 1 in 3 taking painkillers in between their flares. The group from Basel have the Swiss IBD cohort, and in that group, which they published in 2016, 71% of patients experienced pain, and in more than half it was long-standing. And all of these studies show that pain affects your quality of life. And in fact, this German study back in 2010 showed that almost 90% of patients with IBD in an outpatient setting complained of pain. And while surgery reduced pain, patients on analgesics in that cohort reported more pain and lower health-related quality of life, suggesting that actually dishing out painkillers to these patients may not really be all that it's meant to do. So if you used painkiller use as a surrogate marker of frequency of pain in IBD, this approach is a little bit fraught with problems, because it's very difficult to document how much painkiller use there is, because a lot of things like NSAIDs, for instance, can be brought over the counter. So it's difficult to estimate the exact use of these medications. But surveys have shown that 50 to 75% of IBD patients report using NSAIDs, compared to 10% of general gastroenterology patients. That's a big number. So we suggest that compared to our other patient cohorts, IBD patients have pain as a bigger problem, which tailors very nicely what the IBD patients are actually telling us, that pain is a problem for them. There has been a lot of interest in opioid use, and that's because of all this epidemic of opioid use that has been described initially in the United States, but something that is a problem both in the UK and in Europe. But the problem with the literature when it comes to how much opioids are used by IBD patients is really fraught with problems, because the definition of what narcotic uses and what opioids are actually included in that cohort of narcotics varies between studies. And it ranges from 3.8% from this large national inpatient database study of 47,000 patients from Poly in the United States to about 70% from this small hospital-based study from Millie Long, which was 70%. But if you really look at sort of headline figure, about 20 to 30% of patients with IBD will end up getting opiates at some point in their disease course. So we were interested in looking to see what the trends of IBD of opiate use in IBD patients is, and this was a study that my research group did. Nick Barr, who's my fellow, looked at a UK GP database called Research One. This is one of the largest UK databases available, has more than 8 million patients. We validated this database for use with IBD patients and looked at an incident cohort of patients. These are patients who come into our database and are diagnosed with IBD a year after they come into our database, so we have the full record of the medications that they have received. And what we showed over time between 1990 and 2013 is that the number of patients with IBD who received an opiate prescription jumped from 10% in the earlier cohorts to about 30% in the later cohorts. And 34% of patients with Crohn's disease and 27% of patients with ulcerative colitis were prescribed an opiate by the time they reach 10 years of disease. So about a third of patients will be given an opiate. And standard teaching in medical school is do not give opiates to patients with IBD. In fact, when we started doing this study, my colleague who is an IBD physician and shares an office with me told me, why are you doing this study? This is very well known. Nobody would give opiates to patients with IBD. But you know, the data was very different to what perception was at that point in time when we started doing this work. But the thing that really matters to public health is the dollars and pounds. And really the reason pain is important is because patients find it a problem. But pain is also important because it's one of the consistent risk factors for readmission rates into hospital. So this is a systematic review that was done by Sid Singh's group in University of California. They looked at all hospital readmission rates after medical treatment for inflammatory bowel disease. The 30-day readmission rate after medical treatment for IBD is almost 1 in 5 and 1 in 4 when it comes to 3 months. Patients get readmitted quite a bit, and that's expensive. You don't try and keep patients out of hospital, that saves money. And the most consistent risk factor for 30-day readmissions in that systematic review was pain control, inadequate pain control, where you're more than 2 times likely to get readmitted if your pain wasn't controlled at the outset of your admission. So, what are our current options really when a patient is in front of us when it gives standard pharmacological treatment? So you could give them NSAIDs. They're mainly used by the rheumatologists for extraintestinal manifestations. In fact, many of our patients who go to the rheumatologist are often prescribed an NSAID if nothing else works. But they could exacerbate flares in some subgroups of patients with IBD. You could try opioid medication. There is some evidence now that low-dose naltrexone and opiates can have an immunosuppressive effect, but there are no really good controlled studies to show that they are beneficial. In fact, most studies seem to suggest that they can exacerbate disease flares, they can increase surgical interventions, and actually increase mortality in patients with inflammatory bowel disease. There is a high risk of developing dependency with opioids, and you could induce narcotic bowel syndrome in many of these patients. There's also been a use of antidepressants and anticonvulsants like gabapentin and pregabalin, but unfortunately there aren't many randomized controlled trials that are available for these medications for pain in IBD. So we'll touch on that in the next few slides. So what about the role of conventional NSAIDs in IBD? These are non-selective COX inhibitors. So there has been there had been a lot of initial small studies, and those are the ones that I've listed in red on the top, which had a few cases that all seem to suggest that if you give NSAIDs, that increases your risk of flare. But the later studies, some of which were larger, especially the study that came from Manitoba, from Bernstein in 2010, did not show any increase in flares in patients with IBD. But conventional wisdom is that treating IBD with NSAIDs increases your risk of flare, and that's something we tend to avoid in this patient group. And I'll show you some other unpublished data that we've looked at, looking at how NSAIDs affect patients with IBD. What about COX-2 inhibitors? Now, none of the studies with COX-2 inhibitors actually showed any increase in the risk of flares. There are two problems with these studies. One is that they were all sponsored by manufacturers of COX-2 inhibitors. And two, the other problem is that COX-2 inhibitors were later found to increase your risk of cardiovascular mortality, and many of them have been withdrawn, other than celecoxib, which is available in the UK. There are some rheumatologists who continue to use celecoxib, and the initial studies on celecoxib suggest that they are actually safe. They do not increase your risk of flare, but the data is sparse, and we really don't have good evidence base here. What about paracetamol? Now, we always say paracetamol is safe, but does the data bear that out? Actually, there are 3 studies that look at paracetamol in the risk of flare in IBD. But we must look at paracetamol in a different light, thanks to the recent Cochrane review that showed that paracetamol is not effective in the treatment of pain in any condition, and actually increases the risk of heart attacks and cardiovascular complications. And so, really, should we be using paracetamol on these patients? Of 3 studies that have been done, the largest study, which was from Dominitz in 2000, and an earlier study that actually came from David Rampton's group in 1983, right here in London, did show that using paracetamol was associated with the higher risk of relapse. Now, is this because of paracetamol, or is it because patients with pain are more stressed and stress causes a relapse? Is difficult to say, but I think it's important to realize that what we consider safe and what conventional wisdom and practice in the IBD clinic would be is use paracetamol may not really be all that it's cracked out to be. So we were interested in looking what the long-term effects of NSAIDs in inflammatory bowel diseases, and this was from a work done again by my fellow Nick, who was looking really to see whether NSAIDs and aspirin could reduce your risk of colorectal cancer in inflammatory bowel disease as a chemopreventive agent. But we also looked to see whether they were safe to use in this condition. And what we found was we did a nested case control analysis here. So we matched patients to make sure that we had the best possible match between cases and controls for reasons for taking NSAIDs and for the outcomes of interest. And we found that if you take NSAIDs, you're more likely to need steroids, which is a surrogate marker of having a flare. So you're 1.5 times more likely to have a flare needing steroids. And what has never been described before, which is that if you give an NSAIDs, then you're almost 2 times more likely to need surgery, a resectional surgery, within 1 year of being given a prescription of steroids, which again is an indication that NSAIDs don't really help your IBD patient in the long term. So what about opioids in IBD? How good are they in actually treating what you set out to do, which is the pain in patients with inflammatory bowel disease? So we heard earlier from several talks that 26% of cases that came to Pittsburgh were on opioids, and that's something that we saw in our study as well. 1 in 3 were given opioids. But in this longitudinal study that came from Coates this year, they found that 40% of patients had abdominal pain, and opioid use was associated with abdominal pain. But patients started on opioids demonstrated no improvement in abdominal pain when we followed them up 1 year later. and their quality of life did not improve. And this was the same when you took opioids or didn't take opioids. So actually opioids didn't do anything to these patients. It might have been a crutch for the physician and for the patient, that they were being given something for pain, but it did not help them, either their pain or their quality of life. So this was another study that looked at pain in a bit more detail. They looked at the pain scores of 57 Crohn's disease patients. This was a retrospective study, which does carry a little bit of worry, because you normally don't expect people to do pain scores in a retrospective study. But what they did show is that whether they were a user of opioids or not, if you admitted them into the hospital and treated them, most patients had a 1-point drop in their pain score after the admission, suggesting the opioids really didn't change their pain over that hospitalization, because the change in pain scores was negligible. But what was surprising is that almost half of these patients were discharged on an opiate from hospital, and of those, 70% were not on opioids on admission. So they were given the opioids during the admission and discharged on opioids when opioids make no difference, which is surprising. Now, that the indicator that opioids could cause increase in mortality came from the TREAT registry, which was looking at the data from infliximab, and they found that on univariate analysis, the use of opioid medication was associated with a 1.79-fold increase in death. However, this did not remain significant on a multivariate analysis, but it did give an indicator that opioids might have effect on mortality. Again, after surgery, the use of opioids was looked at in a very large 1,331 patient retrospective study from the Cleveland Clinic, and opioids were associated with use of preoperative opioids was associated with an increased length of stay. So patients were given opioids, had a longer mean length of stay, 11 days compared to 7 days if you weren't given an opioid. And they were more likely to develop postoperative complications, 52% versus 40%, which in this large data set was fairly significant. And they found that on multivariate analysis that it was preoperative narcotic use that was the only risk factor in this patient group to cause both the increased length of stay and the postoperative morbidity, suggesting that even in situations where there is need for acute pain relief, opioids don't really help your patient. But what about the effect on mortality? This was a study from the Manitoba group, published 5 years ago, where they looked at the effect of opioid use and who becomes an opioid user in IBD. But the surprising thing they found was that heavy opioid use, which they described as 50 micrograms of morphine or equivalent every day for at least a year, increases your mortality at least 3-fold. But if you abused other substances like heroin, your mortality rate went up 11-fold. But if you're on any psychoactive drug, then your mortality rate went up 1.6-fold. So all of these were significant on multivariate analysis. We were interested to see, as when we looked at our epidemiology of opioid use from the Research One database, we were interested to know what kind of opioids actually were associated with increased risk of death, and whether opioids were associated with increased risk of death in our population. So our studies make for very interesting reading. Actually, what we did find is that if you were given a strong opiate, which is a morphine or a morphine type drug, buprenorphine, fentanyl, things like that, if you had more than 3 prescriptions per calendar year, you had more than 2-fold rise in death in this population, so they're 2 times more likely to die sooner. But these effects were worse when it came to ulcerative colitis. So patients with ulcerative colitis seemed to do worse. You needed anywhere between more than 1 prescription a year was associated with a more than 2.5-fold increase in death in the ulcerative colitis population. And this was true even if they were given codeine. So in patients with ulcerative colitis, we urge extreme caution in the use of opiates because that does increase your risk of death. with codeine or with strong opiates. We did not find any such association with tramadol, but does that mean tramadol is safe? That's an interesting question to ask, but it has to be taken into account of the fact that this was the Manitoba study from Bernstein's group, and what they showed was the blue line is patients who had opioids prior to being diagnosed with IBD, so they had experienced opioids, compared to those who were opioid naive at the time of diagnosis of IBD. They were 9 times more likely at 5 years to become heavy opioid users. So you can extrapolate that a little bit and say, if you give patients opioids and follow them up, they're more likely to turn heavy opioid users at some point than if you do not give them opioids. So I would urge extreme caution in prescribing opioids to patients with inflammatory bowel disease. What about antidepressants? Now, it does have the potential to be efficacious. There are studies in use of antidepressants in IBS and other pain conditions, and it has been shown to reduce the use of opioids in other conditions. But this recent Cochrane review found that there were only 4 studies with a total of 188 patients. Out of these, 3 had placebo-controlled studies. 1 was just a cohort study, and there were SNRIs, SSRIs, and tricyclics in this group. So it was a variety of medications that were used, but no studies reported on what was important here, just the pain outcome. All they showed was that anxiety and depression improves if you give them antidepressants, which would be very surprising if it didn't. But pain outcomes, unfortunately, were not reported in these studies. So I think we still need to look at what happens to patients with IBD and pain if you give them antidepressants, and are you able to reduce their opioid use if you give them antidepressants in larger cohorts? I think that would be essential. What about anticonvulsants like carbapenem and pregabalin? They have been used to treat visceral pain, and there are studies on these in IBS, which suggests that they have beneficial effects on visceral hypersensitivity. But they are starting to get a bit dated now. The 2 studies that I found were from 2005 and 2007. But we need randomized trials again in patients with IBD. As you do know, both of these drugs have now been reclassed as being class 2 drugs. So they are controlled substances, and they have been shown to have addictive properties as well. So again, we need to be cautious about the use in chronic inflammatory conditions, and so that's why we need randomized trials to show that they are efficacious, reduce opioid use, and or reduce pain, both of which would be a welcome change in this subgroup of patients. Now, this is not my area of expertise in looking at what novel treatments there are for pain. We heard a lot of receptors that are being targeted now. So nociception receptors or NOP receptors are one such target. And in animal models, they've been shown to decrease the number of animal pain responses by using synthetic NOP agonists. But these are only in animal models again. Much of the other newer medications are on opioid-based treatments. So these look at things like peripheral opioid receptors, like the kappa receptor or the mu receptor. The kappa opioid receptor agonist called asimadoline has been actually trialed in patients with IBS, but is not currently commercially available. And there are going to be issues with the use of opioid receptor agonists because now that the FDA has clamped down on the use of opioids, these drugs are going to have to go through quite a tough regulatory process before they start becoming available. There are plant-derived opioid receptor targeting compounds. There's a South American plant called Salvia, I forget the other name for it, but salvinorin is the compound that comes from this South American plant that has been used again in mice models of colitis and has been shown to reduce their nociceptive responses. But there's a long way off before any of these make it through phase 3 trials and into our clinic. So to conclude, pain is a frequent and important symptom in patients with IBD. There are multiple reasons. It's multifactorial, this pain. It's under-recognized by physicians. It's an important reason for readmission into hospital in these patients. Conventional painkillers could increase the risk of flares and potentially increase the risk of surgery. COX-2 selective inhibitors are probably safer from the GI point of view, but have cardiovascular toxicity and so have fallen out of favor. The use of opioids has increased over time in the IBD population, but they do not improve abdominal pain or quality of life in patients with inflammatory bowel disease and are associated with increased mortality and increased rate of post-operative infections. Tramadol and codeine, especially in Crohn's disease, appear safer than stronger opiates like morphine and fentanyl, but prior opiate use is associated with future opiate abuse, and so again, we must exercise caution in the use of opiates in this group. We do need RCTs on the use of antidepressants and anticonvulsants like pregabalin. There are some newer drugs in the pipeline, like I mentioned, but they are a long way off before they are used in clinical trials. But no matter which new drug we get, we need close post-marketing surveillance using data sets like GP data sets to show that once they're introduced into the market, these drugs do what they're supposed to do and are as safe as they are in many clinical trials, because as we know, many clinical trials have a very closely monitored group of patients who are put into these trials, but once they're released into the market, they get used on a variety of patients and the effects can sometimes be unpredictable. Thank you very much, and I'm happy to take any questions.